Capital 3 Sonography with a new series, #Draw With Me. Today's edition, Liver Protocol. Today's video will take you through the basic 14 images that are needed to fully evaluate the liver by ultrasound. So let's draw. When I take a look at protocol images, I like to kind of map it out on a large drawing of the area that I'm imaging. So here I'm going to start out with an aorta. We know the aorta sits more posterior to the liver and to the left of the patient's spine. We also have the IVC in the posterior portion of the body, more to the patient's right, and again posterior to the liver. The liver then is a very large organ that sits in front of these two main vessels. The liver sits in the right hypochondrium, the epigastrium, and can extend all the way over into the left hypochondrium. So I'm going to add in the portal system. We know we have the main portal vein dividing into the right and left portal vein. And then I also want to add in the hepatic veins. So we have the right hepatic vein, the middle hepatic vein, and the left hepatic vein. Let's go ahead and add in some organs that we see around the liver as well. We'll start with the right kidney, which we know sits a little posterior to the liver at the inferior portion on the right side. We'll also add in the gallbladder next, which also sits on the posterior portion of the liver. And then lastly, let's get in the pancreas that is more inferior to the left lobe of the liver. Now there are 14 basic images that you will be taking with the basic protocol that I'll be presenting today. So as we're preparing to image the liver, we want to make sure that we are sweeping all the way out, all the way past the visualization of liver parenchyma. Then we're going to go ahead and optimize our images to the correct depth and settings for the left lobe. We're going to start with the long left lobe lateral, which is at the very edge of the left lobe towards the patient's left. We're then going to sweep a little bit more medial or to the patient's right and take an image at the level of the aorta. Continuing in the longitudinal plane, we are going to then move a little more to the right and stop at the caudate lobe where we can see the ligamentum venosum, ideally sitting between the IVC and the aorta. And then lastly, for the long left lobe, we're going to grab a picture at the IVC. Since our depth and everything is set appropriately, we want to change our transducer to the transverse plane, and this will walk us through from superior to inferior, imaging the transverse left lobe. So first we'll start at the superior portion of the left lobe, making sure that we're above any major vessels. We're then going to move inferior on the patient's body, stopping again at the ligamentum venosum and the caudate lobe. And then lastly, we're going to move a little bit more inferior, catching the bottom part of the left lobe, imaging at the level of the ligamentum teres. We'll then want to increase our depth so we are able to visualize all of the long right lobe as it's much larger than the left lobe. We may need to change our focal points, change our frequencies, or penetration of our machine settings. We're going to start with a long right lobe medial picture that is going to cut through the right portal vein and the gallbladder. We'll then move more towards the patient's right, imaging the area of the right kidney and the liver at their interface so we can compare the parenchyma of the two. And then lastly, in this long field, we will slide all the way to the patient's lateral right side to catch an image towards the diaphragm. Turning our transducer into transverse then, we are going to start working on the transverse right lobe, just like we did on the left lobe, working superior to inferior. Our first image on the right lobe is going to be of the dome. We want to be way above all of the blood vessels, getting that very tippy top corner of the right lobe. Moving inferior on the body then, we are going to stop at the level of the hepatic veins as they empty into the IVC. Moving again inferior, we're going to take a look at the right lobe of the liver at the level of the portal veins, And then lastly, we'll move to the inferior tip of the right lobe of the liver, looking at, again, the interface between the right kidney and the right lobe of the liver. Now it's going to be important that we keep in mind, although we are learning about multiple landmarks that we'll want to see in all of our images, it's very important that we remember that these are liver images. There's going to be times that you're going to be focused highly on those landmarks, like the aorta, and you're going to spend all this time clearing out the aorta, but what are you doing to the picture of the liver? Are you making sure that that is always diagnostic? That is our first and foremost, is that we are taking a look at the parenchyma of the liver to show the radiologist. Remember too that this is just a basic protocol. There's only really 14 images in it. Your job as a sonographer will be to look through every millimeter of liver tissue that is visible, and then to take representative pictures of the anatomy that you see. So let's go ahead and take a look at each level and take a little bit more of a detailed look as to what we can see. If you are interested in having pre-drawn sectors, you can follow the link in the video description box below, or feel free to always draw your own sectors as well. So we're going to start drawing our heart on the superior side of our picture, which is on the left side of the screen. The long left lobe lateral picture always is pretty much going to have the heart on the top, and then right below it we are going to see the diaphragm. The diaphragm typically shows up as a bright white echogenic line, again always superior to the liver tissue. Go ahead and draw in a triangular piece of liver tissue representing the most lateral portion of the liver. Now the left lobe of the liver doesn't necessarily have landmarks, but rather lack of. So what we'll see over here is no aorta. We don't want to see any major blood vessels running through the liver tissue. We do want to see the diaphragm. We'll probably see a little bit of the heart, and we might see some bowel sitting posterior and inferior to it. So let's go ahead and label our picture then. Again, we have the heart at the superior portion. Moving inferior, we have the diaphragm. And then we are seeing the left lobe of the liver in the lateral view. Over on this corner of the body, it's not uncommon for us to have some bowel in the area, especially since the stomach and part of the colon and part of the small intestine reside in this area. A quick note about the long left lobe lateral picture. Depending on the anatomy of your patient, some people have very large left lobes, some people have very tiny left lobes. So if you have a patient that has a longer left lobe, what you'll want to do is first take an image which includes the diaphragm and the heart and the superior portion of that long left lobe lateral plane. You'll then slide directly inferior, staying in the same plane to show the inferior tip of the long left lobe at the lateral slice. So these images here are two separate images that have been taken, one a little bit more superior and then sliding inferior. Moving towards the patient's right, then we're going to stop at the long left lobe aorta level. So again, we will start with the heart in the superior portion of our picture, which is again to the left of our screen, followed by the diaphragm, which is directly inferior to it, dividing the thoracic and abdominal cavities. Here we'll draw in our liver tissue parenchyma, and then we're going to draw in our main landmark for this image, the aorta, making sure that we're going to see a couple of major branches as they come off the anterior portion of the aorta. Some other structures that we can see in this image are going to include smaller structures such as the spine posterior to the aorta, and really if you can see that much spine, you probably should reduce your depth a little bit. But we can also see the esophageal junction, usually shows up as a hypoechoic ring. Next to that we have the diaphragmatic crux, specifically the left one, which connects the diaphragm to the spine. We can also see the splenic artery in the transverse view, part of the pancreas, and inside the liver we can see some structures that have bright, thick walls. These are going to be portal veins, or sections of. And then we can see other structures that appear to have thin or isoechoic walls, which typically represent hepatic veins. So let's go ahead and label our picture again, starting with the heart and the superior portion of our image, followed by the diaphragm moving inferiorly. And a larger section of the left lobe of the liver at the level of the aorta. We want our aorta nice and extended along the posterior portion of our image, showing both the celiac axis, which is the first branch of the aorta, and also the SMA, or superior mesenteric artery, the second major branch of the aorta. Again, the spine can sometimes be seen posteriorly to the aorta. These are the vertebral bodies of the thoracic. We can again see the esophageal junction, where the esophagus meets up with the stomach, the diaphragmatic crux, the splenic artery, and the pancreas. Inside the liver, again, we will be able to see portions of the portal vein, which are demarcated by thick, bright white walls. And they'll also see portions of the hepatic veins, which typically have thinner and isoechoic walls. Now in this picture, the aorta is the major landmark for this image. You'll want to make sure that you have it again extending across the screen as well as possible, showing at least the celiac axis, if not both the celiac axis and the SMA in your image. The diaphragm should also be visualized well, and you should always be able to see the inferior tip. Again, if you are unable to, we can do the same thing that we did for the lateral and slide inferiorly on the patient, staying in the same plane. The other structures within this image, such as the pancreas and the esophageal junction, are important to be able to recognize in the event that something appears abnormal, but are not necessary to show in this image. As mentioned earlier, again, we can show the superior portion of the liver, showing the diaphragm and the heart and the superior side, showing that we also then need that second image by simply sliding down the patient's body inferiorly towards their feet, staying in the aorta plane to show that inferior tip. Moving then to the patient's right, we are going to stop now at the caudate lobe. Again, starting with the heart at the superior portion of our image on the left side of the screen. We're going to follow that again with the diaphragm. And then we will draw a section of our left lobe of the liver. What you'll notice underneath this, though, then, is a second kind of hunk of liver that is the caudate lobe. The main landmark that you're looking for in this area, being exaggerated, is called the ligamentum venosum. It is a bright white echogenic line that divides between the left lobe and the caudate lobe. Again, we can see some sections of portal veins. We know these are portal veins because they have bright white, thick walls. We can also see the splenic artery again, part of the pancreas, and part of the splenic vein. Let's go ahead and label our picture then, again, of course, starting with the heart, the diaphragm, the left lobe of the liver, the caudate lobe, and our major landmark, the ligamentum venosum. Let's go ahead and label some other structures in our picture as well. We have portal veins, the splenic artery, pancreas, and splenic vein. Now what I like about this picture is that we really are showing that caudate lobe nicely. We're showing all the way to the posterior side of it. And what I've seen in the past that a lot of students tend to kind of clip the caudate lobe, not increasing their depth enough to see all of the caudate lobe. This caudate lobe image also shows us that the caudate lobe does sit more on that superior portion of the liver on the posterior side. This is also a good example showing the ectogenicity comparison of the liver compared to the pancreas. Moving again to the patient's right for our long left lobe at the IVC. This is the last picture that we will take of the left lobe in the longitudinal plane. Again, we will begin with our heart on the superior side. We know that the IVC pierces through the diaphragm and empties into the right atrium. We will draw part of the diaphragm that we can see, followed by a portion of the left lobe of the liver. In this picture here, we do see a little bit of the ligamentum venosum. Ideally, we will be beyond the caudate lobe, sitting well past where we can see the ligamentum venosum, but sometimes it is not always possible. Posterior to the liver then is the IVC, which is typically a flexible tube with variability that goes along with the patient's breathing. And we can also see a hepatic vein emptying into the IVC. The variability of the shape and the hepatic veins emptying into is proof that we are definitely looking at the IVC. Labeling our image again, we have the heart, followed by the diaphragm just inferior to it, and the left lobe of the liver. The IVC will be in the posterior portion of our image, with ideally a hepatic vein seen emptying into it. As you are making this picture pretty, it is ideal to try to get most of the echoes out of here. We are partially taking this image to just show the relationship of the hepatic veins to the liver, make sure nothing's blocking them or that they're dilated at this level. All right, turning into the transverse plane, we are going to angle all the way up to the patient's head. I like to aim a little bit more towards the patient's left shoulder so I can get this image nicely. So here we're going to start with the left lobe of the liver. We are above any major blood vessels. We don't want to see large hepatic veins. We don't want to see large portal veins. We can see the diaphragm posterior to it. And from the angle that we are coming at this left lobe, we are also going to see the heart in the far field of our image. Remember, we're kind of right under the rib cage in a subcostal viewpoint, angling again up towards the patient's left liver to kind of get what some people think look like a flag of the left lobe. Note on this picture that we are seeing all the way to the lateral tip of the left lobe. We want to make sure that we do not cut off the left lobe. In the event that we are, if a patient has a rather large left lobe, we might need to then slide or angle slightly, taking a second picture, making sure that we're seeing all of the anatomy at each level. Angling the probe inferior now towards the patient's feet, we are going to then stop at the level of the caudate lobe again. So again, we are going to have most of our screen showing as much left lobe as possible. We are going to see the ligamentum venosum again with the caudate lobe underneath. This is again another prime spot that students tend to clip the caudate lobe, not being able to see it fully because their depth has not been increased enough. Remember, it's a very posterior lying lobe. In this image, we can now see the IVC as it serves as a landmark of the caudate lobe, and we can also partially see the aorta sitting more medial to the liver. Again, we have bowel in this area and stomach in this area, which causes artifact. Within the liver then, we are seeing some other structures. Again, anything with thicker walls tends to be a portal vein. Thinner walled or isoechoic walls tend to be hepatic veins. And this picture kind of looks like a shark, a smiling shark. So that left lobe makes the nose of the shark. The caudate lobe makes the bottom jaw of the shark. Again, the ligamentum venosum serves as a major landmark for this picture. We should be able to see the IVC, possibly part of the aorta depending on gas in the area, and we might be able to see some other structures such as hepatic veins and portal veins, although they are not major landmarks. Now when you are getting this picture, it will be important to again see all of the left lobe. The IVC, if you recall when we were going in our longitudinal planes, the IVC served as the last image of our left lobe before we get into the right lobe, or technically the quadrate lobe. We'll be imaging this portion of the liver in different slides as we move into the right lobe. So if your patient has a very large left lobe, you can slide that IVC all the way to the left side of the image, so you can again try to completely image the left lobe with this one picture. If you're unable to, again, you can always slide to the patient's left to grab more pictures at this level. Moving again inferior on the patient, we are going to stop then at the inferior portion where we can see the ligamentum teres. This picture typically has just a kind of triangular small slice of the liver, as it's a very inferior portion of the left lobe. The major landmark for this picture then is the ligamentum teres. It usually shows up as a very echogenic triangle or round structure within the parenchyma of the liver. Now this is a very central portion of the body, so there's actually lots of other structures that we can see. We can see the pancreas just inferior. We can see the SMA and the aorta as well. We can also see the splenic vein as it courses along the pancreas tail and body, heading towards the portal confluence. Labeling our image then, again, we are seeing the left lobe of the liver. Our major landmark is the ligamentum teres. Sometimes you'll see posterior shadowing behind the ligamentum teres. We again can see the aorta in this view, the SMA or superior mesenteric artery, the splenic vein as it's heading towards the portal confluence, and the pancreas. Remember this view when you're having a hard time finding the pancreas. There's also a lot of bowel, such as the duodenum and the stomach in this area, which can cause some artifact in surrounding areas. Remember again, this is a left lobe picture, so we want to make sure that we are decreasing our depth and changing our focus to be appropriately set for the left lobe of the liver, not the pancreas, not the aorta. This is a liver picture. As we move to the right side of the liver, we need to remember that the right side of the liver is quite a bit bigger than the left lobe. So we are going to want to immediately increase our depth, and then we're going to double check what does our penetration look like on our picture. If we are not seeing very clearly to the very posterior portion of the right lobe, make sure that you are changing your frequencies, maybe lowering them, or changing your resolution, general imaging, or penetration abilities on your machine. If you look on the picture on the side here, we have again our IVC running here. Remember, this was our last picture of our left lobe. If you get lost on your way to getting to your long right lobe medial picture, Go back and find the IVC and simply move further to the patient's right. So remember again, we are in the long plane. So the superior portion of the liver is on the left side of our screen. The inferior portion is on the right side. Again, our transducer is in contact with the anterior side of the body, and posterior structures are found opposite. Again, we can see the bright white line that represents the diaphragm that sits along the superior and posterior portion of the liver. Our main landmark for this is going to be a cross section of a portal vein connected to the MLF, or main lobar fissure, which connects us to the gallbladder. There will be other structures, other vessels that you'll be able to see in this image as well, but you must see the cross section of the right portal vein connected to the MLF, or main lobar fissure, connected to the gallbladder. In some people, you will also be able to see part of the kidney. If the kidney is present and is not clearly the kidney, please label it as kidney so it does not catch the attention of the radiologist and question if there is a tumor or mass in that area. Superior, again, remember, is to the left of our screen, so we have the pleural space. We are to the side of the heart at this point. We can see the diaphragm again as that bright white echogenic line. We are now imaging the right lobe of the liver, which is much bigger, should take up most of our screen. Then we want to make sure that we're seeing the portal vein. Connected to the MLF, or main lobar fissure, which is then also connected to the gallbladder. If it is in your picture, make sure to label your right kidney if it is not clearly a kidney. As you are imaging this picture, the portal vein and the MLF area tend to be very highly attenuating structures, and so you may need to change your TGCs. You may need to find a different window to, you might need to find a different window to get around the shadow that those structures create. So make sure you are still seeing all of the parenchyma of the liver at this level. We're going to continue with our protocol in moving even further lateral towards the patient's right on the right lobe. Again, the liver is going to take up most of our screen. In this image, though, we will start to see the right kidney. The right lobe, right kidney image serves as a way to compare the echogenicity of the kidney compared to the liver. On that posterior superior side of the liver, we are going to again see the diaphragm, and we should be able to see the right kidney in the mid plane. There should be plenty of sinus, that central bright area of the kidney, and plenty of cortex, the darker area of the kidney. You'll most likely also see some smaller blood vessels running through this area. And again, we will see the lung or pleural space sitting superior to the liver. Labeling our picture then, of course, we will see our diaphragm. We will evaluate the liver parenchyma at this level. And then we will compare this to the echogenicity of the right kidney. This level is also a common level to measure the liver, measuring from the inferior tip to the diaphragm. May require a second picture to adequately see both the inferior tip and the diaphragm at the same time. The bright white line between the liver and the kidney represents Glissen's capsule and the renal capsule that we can see well. We want to check this area for any fluid, as this is called Morrison's pouch and a common space for fluid. Our next picture then is a very, very lateral picture of the right lobe of the liver, moving all the way off to the side as far as we can before we exit the liver parenchyma. Again, we are going to see the liver taking up a good portion of our picture. And our major landmark in this image is to see the diaphragm making kind of a backwards J shape. Again, we're going to see it plenty of the diaphragm superior to the liver, and also see how it wraps on the posterior side or liver. We're going to be able to see some more of that pleural space. This is an excellent spot to evaluate for fluid in the pleural space. So our major landmarks for this will be the diaphragm, and the right lobe of the liver with very tiny, if any, blood vessels. This picture can be kind of tricky for new scanners. What I encourage you to do is look at your transducer when you go to get this picture. Make sure that you stay in a true longitudinal plane. A lot of people tend to want to start to oblique their transducer, and once they do, they kind of end up in between this image and the next image that we'll talk about. So again, make sure your transducer is truly up and down as you angle all the way to the patient's side. Our next image then is going to bring us into the transverse plane. Again, we are going to start at the superior portion of the liver and work our way inferior. To begin this picture, we are going to start on the anterior portion of the abdomen in the subcostal portion, and we are going to angle towards the patient's right shoulder. It is helpful to have the patient take a large breath in, pushing the dome of the liver towards our transducer. Once the dome of the liver enters into our screen, it'll appear almost as a little cup of liver on our image. We will be able to see diaphragm encapsulating most of this portion of the liver. There should be no major blood vessels in this area, and you'll most likely see the heart off towards the left. So major landmarks for the dome picture. Again, we'll be able to see the pleural space, which is part of the thoracic cavity, being separated from the abdominal cavity. We'll see a cup of right lobe of the liver with no major blood vessels, and we'll be able to see the diaphragm wrapping all the way around the liver. Remember that this picture is actually very far away from where your transducer is in the subcostal region, so you want to make sure that you are increasing your gain as you angle up to help visualize this area. We are then going to start to angle the transducer inferior towards the patient's feet, and we're going to stop at the level that we see the hepatic veins entering into the IVC. Again, keeping your transducer in a true transverse plane is going to be the most helpful, so you don't end up falling in between this picture and the next picture. The liver should take up most of your image. Again, these are liver pictures. These are not hepatic vein pictures. This is a liver picture. We'll see the diaphragm wrapping around the posterior side of the liver. To the left, we will see a round structure that represents the IVC, and we will see vessels emptying into it. Typically at this level, you should be able to see at least 2 of the hepatic veins entering in, most likely visualizing the right hepatic vein and the middle hepatic vein. Again, we can see pleural space behind this area. We'll see the diaphragm wrapping around the posterior portion of the liver at this level. The IVC is typically circular or kind of a squish circle, showing the right hepatic vein and the middle hepatic vein emptying in. Some people think this looks like a bunny sign or a reindeer sign. We might see some other smaller structures, but our major vessels that we want to make sure are in the picture are at least 2 of the hepatic veins. Try that again. Want to make sure that our hepatic veins are clear of any clot, so we will take a look at them, make sure nothing is extending into the IVC. But remember, this is a liver picture. Don't forget to have your patient take breaths in to help you get your images to steady everything. Or you can also roll your patient for the right lobe pictures. It can prove to be helpful to get that right lobe to kind of fall out of the rib cage. Moving inferior on the body, then we are going to then stop at the level of the portal veins. So once again, our liver does take up most of our image as we are looking at the larger right lobe of the liver. We'll be able to see the IVC, the left side of the patient, or towards the right of our image. Again, the diaphragm will be wrapping around the posterior portion of the right lobe of the liver. And our major landmark that we'll be able to see is the right portal vein coursing horizontally across our image. Remember that portal veins have those bright white thick walls. And you may see some other blood vessels, some smaller hepatic veins, but you don't want to see large portions of the hepatic veins at this level. If you do, check your transducer. Make sure that it's a true transverse. So we'll see the right lobe of the liver. We want to evaluate all the way out to the diaphragm. We will see the IVC in this image. Remember, the IVC was our last picture of the left lobe, so now we know that we are seeing the rest of the liver. We have the right portal vein coursing horizontally through our image. And there might be visualization of a small structure anterior to this called the common hepatic duct. Again, if you are struggling to get a nice image of the diaphragm and all of the liver parenchyma, make sure you are using your TGCs to help you see behind some of those highly attenuating structures. Make sure that you are rolling your patient or possibly breathing them. The last picture that we have then for our basic protocol is the transverse right lobe at the inferior portion. When we originally taught this picture, we talked about it being the trans right lobe right kidney picture, and what I found a lot of students would stop the second they saw kidney. There's actually a lot of lobe down at this area, especially if a patient has a Rydell's lobe, in which there's a tongue-like extension going past the tip of the kidney. So we want to make sure that we are sweeping all the way inferior, making sure that we are seeing a big portion of that right lobe. So we're going to see a little bit of the left of the liver at this level, but we still want it to fill most of our screen. We're going to take a representative picture. We might see a little bit of the gallbladder. If you cannot get out of gallbladder, it is okay, but most people have more liver past the point of their gallbladder. You're going to see the right kidney in the transverse plane. Depending on where you decide to take your picture, you might see the superior portion of the right kidney. You might make it all the way to the mid portion of the right kidney. Centrally to the kidney then is the spine, and we can also see the IVC and the aorta in the transverse plane at this level. This gives us another opportunity to compare the echogenicity of the right lobe of the liver, comparing it to the right kidney parenchyma. Remember, gallbladder is not ideal for this picture, but it's okay if a little bit is in there. Ideally, we are just going to know that we've swept all the way out of the liver parenchyma and then came back in to an area that represents this inferior side of the right liver. Again, some other structures that you might see are the spine, the IVC, and the aorta. Knowing that this window opens us up to being able to see the IVC and the aorta might be helpful for certain patients where midline imaging is difficult of the aorta or of the IVC due to excessive gas. Brings us through the end of our basic protocol, 14 pictures, 7 on the left lobe, 7 on the right lobe. Again, remember, you're looking through every millimeter of the parenchyma of the liver, but we're going to take these representative stops along the way to show the radiologist what we saw.